To introduce Phillipa, I had to write all of this down, but we are very pleased to have Phillipa as our keynote speaker this evening, who took on the directorship role of the Wesley Eating Disorder Centre earlier this year. Professor Hay's reputation as a leader in eating disorders comes from a strong background in clinical practice and from being widely published. She has been published in the Cochrane Library and the Lancet Psychiatry, and is the co-editor-in-chief of a journal for eating disorders. Significantly, Professor Hay is a recipient of a 2015 Lifetime Achievement Award from the Australian and New Zealand Academy of Eating Disorders. She's a graduate of the University of Oxford and Otago, and is the founding chair of the mental health at Western Sydney University. Professor Hay, new in her position, will continue her broad-based research program aimed at pushing the boundaries and knowledge of eating disorders. And no doubt throughout this evening that we're going to learn from a lot of that. So may I hand over to Professor Hay. Thank you.
I'm really delighted to be here and delighted to be part of the Wesley program and have this opportunity to contribute to the development of the program further into the future. Tonight I'm going to be talking about eating disorders and some myths and some reality around the prevalence and causes. So I'd like to start with talking about what are eating disorders, who is more likely to develop an eating disorder in our community, what are some of the causes, and what works in treatment. So just to begin with some definitions, a bit boring I guess, but very important. Eating disorders are not an alternative way of life, antisocial behaviour by annoying adolescents, or a social construct misnamed illness. So that's where I start from, where I come from. That's what they are not. They are severe mental health disorders. They cause more disability, that's time lost from work or study, and death than most other illness in young people in our community, and are associated with a high personal and economic cost, both to the person who has the eating disorder and those who care for them, as well as the general community. This publication from the Butterfly Foundation, Paying the Price, it's downloadable from the Butterfly Foundation website. It's the first ever attempt to really cost eating disorders anywhere really in the world, and it's quite a landmark publication. It was commissioned by the Butterfly Foundation and done by Deloitte, and it really underscores the cost of these disorders. When we think about what is a disorder in mental health, really we come back to this sort of classification, which is the one I'm quoting from the World Health Organization, but it's certainly the one that we teach to our medical students, is what do we understand by a psychiatric or mental health disorder. It's a clinically recognizable set of symptoms or behaviors, or both, that are associated with distress and with interference with personal function. So as far as eating disorders, anorexia nervosa is probably the one that's sort of most well known in the general community. It's a disorder of relentless self-starvation with severe weight loss, where there is a denial of the severity of the weight loss and fear of weight gain, and or persistent behavior to prevent weight gain. And weight and shape overvaluation or influence is very high on the person's self-view or self-regard. Other features that are common for people who have anorexia nervosa are using additional methods of weight control, such as using laxatives or other purgatives, self-induced vomiting, or having excessive compulsive driven exercise. Not exercise for general health or team sport, but exercise that's really quite problematic for the person. And I was always struck. Once I had a patient who did not go to her own child's birthday party because it interfered with an exercise regime. So this is not happy exercise. And associated with episodes often of binge eating. That's where eating is felt to be out of control. And you look at that and you think, but isn't that bulimia nervosa? And this is where life can become confusing, because certainly in the general community we often think of self-induced vomiting and binge eating as bulimia nervosa, but in fact if someone is underweight, they would be diagnosed clinically as having anorexia nervosa, although they may have binge eating as well. And often very frequently there are profound mood changes and other psychological problems such as depression and anxiety. So anorexia nervosa first entered the medical textbooks in the 19th century. I think it's always fun to come back to this slide because it shows the sort of cross-channel debate that's still going on. Who was the first person in the world to really define anorexia nervosa? Was it this chap over here with the Union Jack from England, William Gull, or was it Lassagne over in Paris on the other side of the channel? Almost in the same year, they came out and described anorexia nervosa, so they're still sort of fighting over that. But both of them certainly described the illness that we see today in young women. Gull talked about the want of appetite, I believe due to a morbid mental state. So both of them certainly recognised that this was a psychiatric, a psychological disorder. If you're wanting to read any of these accounts, probably Lassagne is the better one I think to read. I think he truly captured much more the sort of conflicts and emotional struggles that people with anorexia has. And he described them as being often occurring in a young woman suffering from some emotion which she avows or conceals, that she thinks to herself that the best remedy for this indefinite and painful uneasiness would be to diminish her food intake and thereby lose weight. So I think he really captured more the essence of anorexia nervosa, but Gull left us with the first pictures really of the first patients that he treated, and this was young woman Miss C before and after treatment at the time. And I'll come back a bit later in the talk to how treatments have developed since those first times of Gull. So the second major eating disorder that's known is bulimia nervosa. It is a 20th century disorder. It was first defined in 1979 by a British psychiatrist, Gerald Russell, who went on to a very well-known, famous career in the area of eating disorders. These are people who have recurrent episodes of binge eating, uncontrolled episodes of overeating on large amounts of food, followed by compensatory weight control behaviours such as self-induced vomiting or taking laxatives or purgatives or driven exercise. Like people with anorexia nervosa, they have weight and shape overvaluation or influence on their self-view or self-regard that's very high. So how they define themselves as a person is very much around weight issues or shape issues that are overvalued. Generally in our community, there is weight and shape overvaluation. If you do what I do and sort of measure these things, weight, shape, overvaluation in our community, there is always a moderate amount of concern about weight and shape issues, but for people with an eating disorder, that is overwhelming. It is the most important, or nearly the most important thing to the way that they define themselves. And it's similar to that, as I said, for anorexia nervosa, for people with bulimia nervosa. Binge eating disorder is again another 20th century disorder, really not well understood or well defined until the 1990s. It's a disorder of recurrent binge eating, as with bulimia nervosa, but there are no regular compensatory weight control behaviours. There may be attempts at weight control behaviours, but they're not regular, and it's associated with distress around the binge eating. For reasons which are debatable, and I probably sit on one side of the debate, having weight and shape overvaluation or body image concerns is not at present part of the defining criteria of binge eating disorder. However, having weight shape overvaluation is very common for people with binge eating disorder, and certainly many people share who have binge eating disorder that concern as with people with bulimia nervosa and anorexia nervosa. But technically you don't need it for the diagnosis. And then there's a couple of new things. If you've been around a little while, you'll have known about EDNOS, which used to have to be explained as eating disorder not otherwise specified. Well, in their wisdom, the American Psychiatric Association in 2013 got rid of EDNOS. So EDNOS doesn't exist anymore. We have instead OSFED and UFED. OSFED is other specified feeding or eating disorders, and UFED is unspecified feeding or eating disorders. And these are people who have an eating disorder that's of clinical severity and important and need for treatment, but doesn't meet diagnostic criteria for anorexia nervosa, binge eating disorder, or bulimia nervosa. OSFED has some specified types, which is why it's called specified. It includes people with atypical anorexia nervosa. And these are people who are very typical and very like people with anorexia nervosa, but they are not clinically underweight. And we are seeing more and more people in our community with atypical anorexia nervosa, people who started perhaps at a higher weight and have not yet got down to being technically underweight, but they are in a state of self-starvation. Bulimia nervosa or binge eating disorder is also a type of OSFED where the frequency or duration of the binge eating or compensatory behaviours doesn't meet diagnostic criteria. Technically, that probably doesn't make much of a difference to the person who has the illness. And night eating syndrome and purging disorder, who are people who have a persistent problem with purging without binge eating. So those are at least our understanding, at least in this day and age, of what is an eating disorder. Who in our community is more likely to develop an eating disorder? And this is where I'm sort of getting into some of the myths. Early perceptions and clinical experience with people who had anorexia nervosa very much thought that it affects young and healthy girls who have been raised in privileged and even luxurious circumstances. Now, this was written by Hilda Brooke, who was a lioness, really, in the world of eating disorders. She was an American psychiatrist who wrote and developed treatments and programs for people with eating disorders in the sort of second half of the 20th century. But this was her view because those were the people that she saw in her clinical practice. And I don't want to diminish at all her contribution to the area, but she did have this perception, and I think it has had some effects. And that was how she started her classic book, The Golden Cage, in 1978. And I think her view of that had unanticipated effects on how we view people with eating disorders. Such that this was from a piece of research I did where we asked some people in the community, women in the community, what happened when they sought treatment or went to see a doctor for their eating disorder. And very often they would say they didn't seem to meet that typical person with an eating disorder. So one of them said, I don't know whether it was because perhaps I was still in the healthy weight range, but she didn't really diagnose it as a serious issue. I would vomit every day, and to me that was pretty serious. So this misunderstanding of what an eating disorder looks like, or the range of people, range of types of behaviours and things people with eating disorders suffers from, I think has an effect on what happens when they seek treatment. Since the 1980s, the DSM and the ICD have introduced the new eating disorders I was talking about, binge eating disorder and bulimia nervosa. And so we started to study it. And we started to report on binge eating disorder having an older demographic and being more common in men. And in 1994, this is a little bit about my story as well, I moved to South Australia and was introduced to something called the Health Omnibus Survey, which is an annual face-to-face household survey conducted on a random sample of around 3,000 adults in South Australia aged more than 15 years. So that happens every year. And I've done 5 surveys in the Health Omnibus Survey between 1995 and the last one was just last year. We've asked people, or included in the survey, asking people about eating disorder and other features. And these are just some of the findings that we've had from these sequential surveys of people in the general community. Eating disorders are common and are increasing, around sort of 1 in 20 in the population of people may expect to suffer from an eating disorder. They are present across all age groups and all socioeconomic classes. Some, but not all, features are more common in women. In particular, binge eating is not more common in women. It's probably similar between men and women. The age of onset for the disordered eating behaviours is most often in late adolescent and young adult years, but they are often very persistent. And this is where we see in our clinical practice people presenting for the first time with a decade or more of having an eating disorder. So we are seeing a lot of adults with long-standing problems with eating disorders, although the onset may still very often be in the late adolescent and young adulthood years. Other findings, and I worked with a very young, newly graduated dietitian, and she got very excited about this data, and she said, but what about obesity, Phillipa? And I said, oh, obesity, I'm not really interested in obesity, but she was quite interested in obesity. So she just looked at the people who were in the overweight and obese range within these samples, and she found that they commonly had disordered eating behaviours and eating disorders, but also that this was increasing, such that in 2005, 1 in 5 people who were in that overweight obese range had a concurrent disordered eating. And this was much greater, almost twice as much as in 1995. So that was increasing very fast, and that was increasing faster than either problem alone, and particularly increasing in young women. I then had another student who got very interested in men, and I wasn't so interested in men, but she was, so she went off and looked at men, and she looked at what was happening for men with eating disorders in these population surveys, and reported that men are now a sizable minority of people with eating disorders, around about, not a majority, under 50%, but somewhere between 30 and 40% of people with an eating disorder now are men. And that disordered eating behaviours were equally debilitating for men and for women, although one thing she did find was that body image disturbance was the one thing that might be more impairing for women, but the behaviours were equally debilitating. And the other thing that we've been seeing in the course of these last years is emergence of new disorders in men, new types of eating disorders. And muscle dysmorphic disorder is currently debated as whether it's an eating disorder or a body image disorder or what it is, but it's certainly present in young men in Australia today and contributing to steroid abuse and other things to build up muscles rather than to be very thin. And we're also seeing more and more younger boys and younger men hospitalised with anorexia nervosa. And we're also seeing older people with eating disorders. And this is just the picture from the newspaper announcement of a British ex-deputy PM, Prescott, when he came out with his bulimia in 2008. And just to underscore the fact that eating disorders can occur any age, any gender, any age, and increasingly in older people as well as younger people. So why does it matter? Well, I think it matters because it likely influences the treatment gap. We know that the vast majority of people with eating disorders aren't accessing care, and the statistics are really quite alarming. Up to 50% of people with anorexia nervosa may never access any form of care, some of the research tells us. And also for people with bulimia nervosa and binge eating disorder, even higher numbers, perhaps 80-90% of people are not accessing evidence-based care. And again, when people do try and access care, they may be met with little understanding because of misperceptions and lack of understanding of the disorders. And also there's been a severe neglect of an understanding of these other groups of people, such as men and older people, both in research and in providing clinical services. So now I want to turn to a little bit about what is our understanding about how these disorders develop. And I apologise to anybody in the audience who's seen this before, because I show it to all my patients and I use this clinically. This is sort of an understanding, it's based on a cognitive behavioural model of an understanding of how eating disorders develop for a person. And our current view is that usually they develop somewhere, starting with weight and shape concerns. But what contributes to those weight and shape concerns, to people not feeling good about themselves and their body image? And very often that starts with a need for control, a self-view that's low, a low self-esteem, and perhaps mood changes. And of course that all relates back to early life experiences that people have had, as well as what culture people have grown up in. And increasingly in our society, being overweight or just even perceiving yourself to being overweight, weight teasing in childhood and things contributes to both the sort of behaviours that people engage in and concerns about weight and shape. And we know that extreme dieting often contributes to overeating and the start of binge eating and the beginning of bulimia nervosa and binge eating disorder. And then there's a vicious cycle gets set up, because the more you binge eat, the more you worry about your weight and shape, the more you feel badly about yourself, and you get into the arrows going round and round. And in treatment, what we are really trying to do is to interrupt and break those arrows down. But I'll just talk a little bit about some of these things that we think contribute to our understanding of the development of eating disorder, and starting with this sort of idea of culture and Westernization. We know that there is no epidemic of anorexia nervosa in the West, but there has been an increase in adolescent girls in the last 50 years, and we know there's been the emergence of these new eating disorders, bulimia nervosa and binge eating disorder, over the same time, and that these are more common in societies which have Western cultural values, where there is what's called an internalization of the thin ideal that is now global. And it's getting increasingly hard in my lifetime to find a corner of the world where thinness is not the idealized view of a body image. When I was younger, we could perhaps go to parts of Fiji or even perhaps parts of Papua New Guinea, but it's getting harder and harder. Eastern Europe, before the wall came down, perhaps as well. But now, really, this has become the global view of how people should be. And this is also occurring at the time, in the 20th century, of a huge growth and a whole new phenomena of dieting and the diet industry. This is really, as I say, really grown in the 20th century. It probably started sometime in the 18th century, and I have on another slide a picture of the first ever set of scales in the world that weighed people. And this was in a London coffee shop. In that time, the London coffee shops, people like to go and drink coffee and things, and they started to get worried about their weight. And some enterprising coffee owner thought, oh, well, I can start weighing you. And he put a chair on the set of scales where you'd usually put a sack of coffee to weigh the coffee. So the person sat on the chair and the weight scales were on the other side. That's the first known example of measuring people's weight. But since that time, and of course, through the 20th century, it has just really mushroomed and becoming normative in our society. And of course, at the same time, we are modern, we are literate, and we are very well fed as well. So you've got this kind of thing happening at the same time as concern. Just to remind you, there was a time when people weren't worried. This is a picture of the Venus of Willendorf. 28,000 years ago, thereabouts, this was the idealized view of a woman. Okay? So quite rotund, really, we would say these days, I guess. Okay? But moving on, 28,000 years or thereabouts, we're now getting worried. This is actually from 1900, so it's not yesterday. It's certainly something that's been throughout the 20th century that people have been worried, and we still see that today. Signs, you don't need to be fat, we've got the diet for you, we can reduce your weight very easily, no problem. And this is, unfortunately, they look thinner than they actually should look. They're not actually quite that thin. But of course, the end result is this idealization of thinness, and we see it in models and celebrities who need to be thin in order to feel successful. So that's sort of the background. So that has some role in the development of eating disorders, but it doesn't explain an eating disorder for any one individual person. And there's some very other important things which contribute to the development of an eating disorder. Very often there are what we call invalidating and traumatic experiences for the person in their formative years, as they're growing up or in their young adulthood. They often have a low self-esteem, but are also people who are driven to achieve. And that kind of combination is very problematic, because if you're driven to achieve and highly perfectionist but never can believe in yourself, you can never get there. However, you may start to gain a sense of achievement and control through extreme weight loss, which is how people's journey into anorexia nervosa may start. Ruska has talked about this as the anorectic self. She wants to be in control of herself, thereby attaining what is an otherwise elusive sense of self-worth. She devises a new controlling self, and then she finds it is in control. That's the eating disorder, is in control. For the anorectic person, not being in control is unacceptable, yet it is also true that the self has little capacity to control her pursuit of starvation. So the starvation, the eating disorder, really takes over the person. However, it's not forever. This is from Claire Park's self-portrait, and if you go and Google Claire Park, she's a British photographer who has a sort of online set of photographs of herself from when she suffered anorexia nervosa to when she recovered and when she became pregnant and had a baby. This is just one that was published in the Independent newspaper, but it shows her at a time when she had anorexia nervosa, and everything is symbolic in the picture. The bandages are because she couldn't bear to look at herself, so her face is wrapped in bandages. The letters are letters that came from her mother at a time, exhorting her to seek treatment, begging her to seek treatment. And the ballet shoes really representing another risk factor, another thing that she experienced in a very sort of anorexigenic environment of ballet dancing. But she wrote about this portrait, and she said the outward visual experience is of utmost importance. And these pictures are all about how you feel ugly inside. However, she does remember a moment when she was released from this view of herself, and she said it was almost like an out-of-body experience. I saw myself for a split second in a mirror, and I actually stopped for 1 second thinking I was too fat. And I saw what I had become, like something out of Belsen, one of the World War II concentration camps. And that was the beginning, that sort of sense of seeing another self that was different. That was her start to the road to recovery. So coming back to causes, that they're complex, they're very individual as well. I'm often asked, is it the media's fault? And I don't think it is. I think the media plays a role only in so much as it's reflecting and reinforcing Western values about the ideal body image. So I think there is something happening there, but I don't think we can really blame the media. What can we do to help? Like the causes, the treatment isn't necessarily complex and usually involves a team with expertise and people with different but complementary skills. Dietitians, doctors, psychotherapists, both individual and family therapists, nurses, other disciplines, social work, occupational therapy, art therapists, and family, friends, and support groups all are involved in the care and treatment. Coming back to Sir William Gull, he wrote about treatment. He thought it was very easy to treat anorexia nervosa. He discovered it, he wrote it up, and he said this is a treatment and it works for everybody. The patient should be fed at regular intervals and surrounded by people who would have most control over them, not their families. So you take control over the person. You can imagine for someone for whom control is a central important issue, having that control taken over must be very devastating at the time. Also, Lassalle was similar. Although he seemed to have a more empathy for his patients, I think a better understanding of what they were struggling with, he also thought it was important for the physician to take control and refeed the person. Well, that was really the mainstay of treatment up to people like Hilda Brooke in their sort of mid-20th century, because it didn't work. People were refed and then they lost weight as soon as they escaped from their physician. And why doesn't it work? This is one of my favourite slides. It really shows sort of the last 1,000 famous women, high-achieving women, one of whom had anorexia nervosa, perhaps more than one, but one I definitely know. And this is this lady here, Catherine of Siena, who was a mystic, proto-feminist, and the patron saint of Italy. And she's really up there with St. Francis of Assisi in terms of high regard in Italy. But she suffered a form of anorexia nervosa. And this is what her biographer wrote about her fasting, that her stomach could digest nothing, her body heat consumed no energy. It was impossible, however, for her to avoid some crumb or juice descending into her stomach. So she also willingly drank fresh water to quench her thirst, and was constrained every day to vomit what little she had eaten. She also regularly and with great pain inserted stalks of fennel and other plants into her stomach so she could vomit, so she could help as emetics. And although some were scandalized by her fasting, she maintained this lifestyle until her death. So she died of self-starvation. But she wrote about it, and I was always struck by what she wrote. She said to a priest, "You wrote to me begging me to pray to God that I might be able to eat. I say to you, Holy Father, that in every possible way I've always forced myself to take food once or twice a day, and I have prayed often, and so will pray in the future that he will help me so that I may eat as others do." And I put that emphasis at the end because I think that is really about recovering. It's being able to eat as others do, not to be refed by others, but to be able to learn to eat as others do. So the goals of treatment are multifaceted. They are to both, as I say, learn to eat as others do again. So that's why meals and being with people while they're having meals is part of the therapy programs here at Wesley and other centres. To restore healthy weight, psychological therapies to understand the person, to help the person with their own personal struggles, and family and carer education and counselling that's the people around the person with the eating disorder. And you need all those sort of 4 parts really for a successful outcome. And the primary goal is to restore the person to full social and interpersonal function, full nutrition, and restore their mental health and restore their physical health. You cannot do one without the other. Psychological therapy without attending to the person's nutritional state doesn't work. Equally, just refeeding by itself without attending to the person's psychological state doesn't work. On a positive note, however, outcomes will be very good. And when I was asked earlier this evening, someone asked me how I got into this area. Well, one of the reasons is because it's very satisfying to see people recover from an eating disorder. And it's one area of psychiatry where we do see people recover, which is fantastic. And at least half of people with an eating disorder or more with some eating disorders will make a good recovery, and the remaining 30% will be much improved. So although we often dwell on the patients, sadly, who don't improve or take much longer to improve, we need to remember that the majority of people do improve and make a good recovery. We do know from the research that people make a better recovery for anorexia nervosa if they are treated probably in a specialist unit. But it may take time. When I first started, my mentor, the person who supervised me first in treating people with anorexia nervosa, she said, "Phillipa, you've got to think this is going to be 1 to 4 years." And so it's about that. But maybe shorter, maybe longer, depending on the person. But it may take time, and you have to allow that it's going to take a little bit of time. You also have to remember it can occur after many years with illness. So I've seen people fully recover from anorexia nervosa after 20 years of illness, for example. So we never give up hope. We never say it's not going to happen, because it can still happen after many years with the illness. So just in closing, just thinking a little bit about prevention. As I said, causes can be very complex. Prevention is often very difficult, but we probably do know enough to develop strategies to identify and target young women at risk, and young men too, increasingly, with a focus on promoting self-esteem and healthy eating patterns. And Australia, with Tracy Wade and others from South Australia, is probably leading the world also in this area of research of prevention, and actually be able to prevent and reduce risk factors for developing an eating disorder, as well as disordered eating behaviours. And in this regard, I think we can engage the media, and they can be very helpful. They are trying to help. Some are coming on board. Some magazines are now not publishing a lot of very, very thin models, or photo shooting everybody so they look unusually thin, for example. So things are happening, and I'm beginning to think that things may begin to turn around for us in the future. So that we can be, as Hippocrates wanted us to be, another ancient physician, pre-Christ, where we have a diet that's not an extreme point of attenuation, which is dangerous, or overly replete with an extreme is also dangerous, but we can eat in ways that we can be positive, feel good about ourselves, good about our body image, and healthy. Just to close, some good books. This is a good book, the first one for people with binge eating and bulimia nervosa, A Guide to Recovery by Peter Cooper. It's quite a short book. It's really a self-help book. I wouldn't necessarily say you should take up self-help therapy, but it's a good place to start, and particularly gives a lot of information about bulimia nervosa and binge eating and cognitive behaviour therapy and how it works. It says the first edition was 1995. It has got a second and third edition, and it's quite easily available on sort of Booktopia or Amazon.com. And a book by Gail Hewen and Brown, which was from the University of New South Wales Press, 1988. Still quite relevant, Fighting with Food, Overcoming Bulimia Nervosa. I just put that one in because it's the Australian sort of version of the Peter Cooper book. And Anorexia Nervosa, A Survival Guide for Families, Friends and Sufferers by Jenna Treasure, published in Psychology Press. Really anything that her group, Jenna Treasure, has written for families and about people who care for people with eating disorders is well worth reading and quite easily obtainable. And websites. There's many, many websites, but these two are in New South Wales, and they will direct you to many other websites. So they have very good resources and direction to both where to get treatment, what eating disorders are, who treats them, how they're treated, etc. So the Butterfly Foundation and the Centre for Eating and Dieting Disorders, www.cedd.org.au. And thank you.